coming back to the initial discussion we have about the access of this drug, multi-specialty collaboration, and I think this is only going to get more and more given nuclear medicine and nuclear physicists are coming into the play now because we are using lutetium, right? So I think we will have more and more of this approach where we're going to have to involve different specialty in care of this patient. Do you have any other thoughts about the whole scenario of newer drugs and how that will be sequenced?
No, I mean, I guess going back to the PSMA and then, failing, let's say, triple line therapy and having, new options like Pluvicto, like we were talking about, just having, I think, that sense of hope, that newer technology, obviously there's going to be cost. So everything comes down to cost and, whether it's going to be covered by insurance. But I think just with advancement of prostate cancer research with these newer lines, maybe monotherapy, but, if you fail all these, then it's almost like there's still hope for the patient saying, well, if we can get a positive, PSMA PET and you fail these other lines of therapy, these radio therapeutic treatments are now, just that next step. Mm-hmm. And so I think it's great. I actually have 2 or 3 patients. I don't know if they're in the trial, so I don't know if they're getting it, the actual treatment versus placebo, but they're actively going through that. Okay. So I think that's an exciting thing for the community.
An important point also, I think, is to understand the influence of PSA, that number, because patients hang on to that number for dear life every 3 to 6 months. Yes. And sometimes with a lot of these treatments, it's very gray in terms of where is my PSA? How come it's not undetectable like it was post-surgery? Yes. Oh, it's a little up, it's a little down. And they live and die by that phone call every 3 months to say, is my PSA up or down? And that, again, you have to kind of set it in perspective, understanding that may not be the absolute judge of how your cancer is doing. We're basing it on bone scan, we're basing it on PSMA, we're basing it on a lot of endpoints. But that is one challenge that I think we all face in terms of how do we explain to our patients that a PSA that's a little bit higher doesn't necessarily mean that you're worse off than when your PSA was lower.
Yeah. I try to introduce the doubling time concept, which usually takes 3 or 4 visits for them to, but just show them 2 years ago your PSA was 3, it's now 3.5. Right. That's okay. It hasn't doubled yet. When it gets to 6, and try to talk about the 10-month. People do start to get that, and they get a little less focused on their 1/10 of a point or 1 point change, but. Yeah, I think that's common because they've had their prostate or they had their radiation, they had their prostatectomy, and they're used to it being low, undetectable or 0.1 or 0.2, and then it's a tough battle.
Yes. So, in the end, I wanted to also highlight, what we do in oncology practices and molecular analysis. So, we obviously has a lot of targeted therapies that we use for, a lot of different cancers, and prostate cancer is obviously not spared from this, and we have some exciting drugs that we have for certain mutations. So I think doing the molecular analysis for every metastatic patient is very standard nowadays, and we always prefer to do it on a biopsy sample if possible. But as we know, a lot of times they have a prostatectomy several years ago, and now we don't have a new sample. And we also we can do a genetic testing on a blood sample. So we do what we call a circulating tumor DNA, and we can then try to identify certain mutations in their tumor cells. So I think that has also added another, different agents that can be available for those patients if they have mutations.
Even in the BRCA1?
Yeah, so BRCA, we have BRCA1, BRCA2, then we have something called HRD, which, PARP inhibitors are approved for BRCA1, BRCA2, and HRD deficient patients. So, immunotherapy is obviously there, even though I think immunotherapy kind of has fallen short in the prostate cancer space, but there are still, occasional patients that may benefit from those immunotherapy if they have certain, characteristics. For example, if they are MSI high tumors, then they can still benefit from immunotherapy. So I think doing that molecular analysis is extremely important for these patients.
I think it also goes to Josh's point that patients are hooked on a number. And then if you give them more data, Like you give them a PSA, you give them a germline test, a somatic test, a PSMA result. Like you're giving them all this data, for prostate biopsies, deciphers, oncotypes. Like you're just giving them data to kind of show them where they're going. Yes. And I'm doing more germline testing earlier now, just so I can show, look, you're not BRCA positive. Yes. That's good, because I think we know that BRCA positive is a bad sign for many guys. So I'm trying to do as much data as I can offer them in the beginning, so I can kind of show them what their next 5, 10, even hopefully 15 years is looking like.
And that's also helpful just for their family history of, the male comes in and, it's like, hey, my dad had prostate cancer, my grandfather, and I got two sons, both, 45 and 50. And so doing that early, like you said, that kind of helps. I think maybe we catch prostate cancer earlier in that next generation if, if it's positive.
Yes.